Good afternoon, everyone. Welcome to the 7th presentation in our Reducing Preventable Hospital Readmissions webinar series here at VHHA. This series, as you know, is focusing on target strategies that we've identified in Virginia hospitals, improving care transitions. My name is Joyce Davalt, and I'm the Director of Performance Improvement here at the VHHA Center for Healthcare Excellence, and I am your moderator for this presentation today. Before we get started, next slide, just a few housekeeping items. This webinar is being recorded and will eventually be posted on our VHHA website, and that takes several weeks for that to happen. The presentation is located in the handout section of your a bar on the side. Yeah, and it was also sent out as a PDF file in an email to you all this morning. Please, when you're on the phone, this webinar platform has attendees in a listen-only mode. However, we have had some times where folks have broken through with background noise, and please do not put us on hold because we will get your hospital's music and advertisements. Though we love you, we don't want it in the recording. So if you, at the end of the presentation today, we ask that you would type your questions you may have or comments in the question box with the speaker at that time. Also, you will have a feedback survey that will come up as you close out of the webinar today, and your comments and responses are very valuable to us as we move forward with more resources for you all. Next slide. Our webinar series, the purpose and objectives have been for us to share successful strategies in our Virginia hospitals and health systems to improve care transitions and reduce hospital readmissions. We also want to encourage transparency and to facilitate networking amongst you all in the healthcare systems and with our community partners. This is just a detail of the series that we have been providing you. Today, of course, is coming from Children's Hospital, the King's Daughters, and we have one more in the series this year, which will be with the University of Virginia on Thursday, December the 5th. So happy Thanksgiving in the interim. Okay. Today's presentation is being presented, as I said, by the Children's Hospital, the King's Daughters, addressing reduction of unplanned readmissions using a multifaceted patient and family-centric approach. I would now like to introduce our presenter today and welcome Cindy Fisher. She is the Director of Case Management and Care Connection for Children at the Children's Hospital and King's Daughters. And key to these efforts, too, with Cindy has been her partner, Adam Campbell. He's Director of Clinical Improvement and Analytics. Though he's not on the call with us today, he has been integral in putting together this process, a successful process, with Cindy and a number of others. So, Cindy, I welcome you. The floor is now yours for your presentation.
Thank you. I appreciate you all attending today and taking some time out to hear about our efforts here at CHKD to reduce our readmission rate. I like to think that Adam is the king of analytics and I'm the queen of case management. And we're working pretty well together. So, sure of our campus here, Children's Hospital of King's Daughters. If you haven't visited, we're the only freestanding children's hospital in the state of Virginia. We can go to the next slide. So this is a really busy slide, and it's what's referred to as the key driver diagram. The work here is based on our involvement with Solutions for Patient Safety, which is a network of about 135 plus children's hospitals who share the vision that no child will experience harm in our care. It's a collaborative teach, learn, and share without competition, with much transparency. And there are several initiatives that this group is involved in, and readmissions has been one of them. When we look at this key driver diagram, we're certainly not going to delve into every aspect of it, but I'll hit the highlights for you. Basically, the aim, of course, is the goal. And then the drivers, the key drivers are the factors that are affecting performance to get towards that goal or aim. And then the interventions are the actions that we take to address the key drivers and move the needle to meet the aim. So what you see under interventions is what I'm going to be talking about, the top 1, 2, 3, 4 boxes there. So we can go to the next slide. So the highlights of what we refer to as the bundle, which is the interventions that were defined, are the following components: the daily visual management, patient and family surveys, feedback on readmission to our discharging and admitting physicians for patients that have been readmitted after a previous encounter in the hospital, improvement in follow-up appointment scheduling, and follow-up phone calls. I'm going to go through each of those for you. This daily visual management is basically a report that comes out and identifies for the unit management patients that have been readmitted within 7 days of their previous encounter. So this would trigger the opportunity for them to meet with the family and discuss the readmission and see what possibly led to the readmission. It also is what would trigger making sure the attending physician who discharged or the attending that has admitted the patient would be aware. What I have to say about this, moving to the next slide, is they attempted to do this, take that report and then use the My Rounding tool to interview patients and families. I would say that this has not worked for us. We found some other ways to get these surveys back from patients and families, but the biggest problem in pediatrics is when it's convenient for you to round, the parents aren't necessarily there to round with. And that's a barrier. So it really has not worked that well. But it's a good idea in theory. So let's go to the next slide. Survey that we use in our emergency department, and I'll get into their process and with you. But this tool was developed with input from our patient family advisors. And we just wanted to ask some questions that would help us get some feedback from the parent's perspective as to the complications maybe that they experienced that led to the readmission, so that we could then identify some opportunities for improvement for ourselves. Next slide. So what we found that did work was to get these surveys completed in the emergency department. We have emergency department case managers here 12 hours a day, 6 days a week. So we're not catching every readmission with the survey, but we do get a good number of them using this method. We have the case manager meet with the family, and they do it as part of an assessment. They gather the information, and then they enter this information into REDCap. We do have it set up where families could actually fill this out for themselves on iPads, but we haven't had enough iPads because the iPads have been used also for language access. So at this point, the case managers are asking the questions, gathering the information, and inputting it into the REDCap, where we can then run reports on it. So we go. The questions are, were you comfortable with providing health care needs of your child? Were you able to ask questions before leaving? Were home care services provided as planned after discharge? Were you able to receive your meds and supplies needed for home care quickly and easily? Were you able to see your primary care doctor or specialist after discharge? And do you think returning to the hospital could have been avoided? And then there's an opportunity for them to comment. So we completed a review of close to 1,000 of these surveys, actually 960. And I'd like to give credit to our patient family advisory team. One of the members stepped up and said that she'd be willing to go through all of the surveys and give us the themes from the comments. And as it turned out, there were about 225 comments in 960 completed surveys. And she came up with the different themes. Communication was accounted for about 13% of the concerns. Concerns regarding discharge instruction accounted for 11% of the comments. Access to medications, insurance, or the providers accounted for 14%. Issues with follow-up with the primary care accounted for 22%, and quality of care accounted for 40%. So all those surveys we are now taking and sharing with our team members so that we can identify areas specific to the encounters so that folks will have the opportunity to give that back to their staff. You know, if there's a communication problem, where was there a theme? Like I said, there were about 225 comments, and if 40% of them were related to quality of care, let's look and see where that is. Where's that happening, and what can we do about it? So that is our activity going forward for improving. Let's see. The next, feedback to discharging physicians. What we do is case management screens 100% of the patients, and when they come in, we get an alert if it's a readmission. So then we take a look and see, is that a planned or unplanned readmission? And if it is an unplanned and it occurs within 7 days, then we send feedback to both the discharging and the admitting physician to let them know that this patient has been readmitted, what was their admitting diagnosis, their discharge diagnosis, what the readmission diagnosis is, and ask them 3 simple questions based on this information. Based on information reviewed, do they feel like there were any obstacles that the family experienced that led to the readmission? And did these obstacles occur during the admission, during the discharge process, or at home? And could we make improvements that would prevent this readmission? We found that this, even though many times we don't get a lot of feedback from the physicians, usually it's no, and that's a good thing, but when we do, it does give us an opportunity to take a closer look at that encounter. So we have found it to be valuable, and it's also, even if they're not commenting, you know, it's good situational awareness about the readmission and that it's something that we take serious and we're looking into further. Okay, so then the next slide is making appointments prior to discharge. That is something that has been found in the adult world that to be very effective for preventing readmissions, to make sure that you have that handoff. So we've done a much better job at figuring out who it is the patient needs to follow up with, and making sure that that physician knows and is prepared for that follow-up, as well as making it easier for us by knowing, and we've built into our database with our Cerner electronic medical record, the phone number. So it's easier to figure out who the primary care physician is and what their phone number is, so that we can help the patients. We either help the patient to make the appointment, or we make the appointment for them, or give them a time frame for which the appointment should be made, and then that's handed off in their visit summary so that the primary care practice can then follow up. So we can go to the next slide. So in addition to the other things that we've done, this has, from my perspective, has probably been the key one in terms of preventing readmissions, because the phone calls that I'm going to discuss with you here are the ones that are made by case management. The reason case management would make the phone call would be if they have set up post-acute care services for a patient, we want to follow up to make sure that those services or those medications that we've gotten a pre-auth for have been put in place. We don't own any home care companies nor DME companies, so we really don't have any control over them. We're just the conduit for making the referral. So the agreement is in between the family and that vendor. And sometimes vendors don't do a very good job of following up. So that puts the patient and family in a vulnerable position. So we want to identify those issues early and intervene. So the way we've accomplished making these follow-up phone calls is to have an ad to tell them that she's following up on behalf of the case manager, and ask them if they have time to answer a few questions, and then they ask about, did the referral agencies contact you as planned? Were they able to get their prescriptions or formula as ordered? Did they feel prepared to care for their child at home? Were they satisfied with the home care agencies? And then, do they have any other concerns? If there's any positive response here in terms of follow-up need, the family is then asked to provide us the best number to reach them, and we get in touch with the case manager right away, and they do a return follow-up call so that we can take care of any identified issues then. And we make these phone calls within 48 hours of discharge. We try for 24, but we give ourselves that leeway. But within 2 days, families are getting these calls. In addition to these follow-up phone calls that case management is making, we now have our primary care physician offices making phone calls to families as well. And all of these phone calls are going into one folder in the electronic medical record, so that if, say, Kim is calling on behalf of case management, then whoever the patient care coordinator is at the patient center, medical home, or primary care practice, they can see this call was made, so they can look and see if there was any information in addition that they may want, just so we're not bombarding families with phone calls, because we want them to know we care about them, but we don't want to frustrate them with multiple calls. We end up making probably, in a busy time, probably a little over 200 calls in a month from the case management office. In the slower times during the summer, probably about 100. So we can go to the next slide. I saw you were trying to do that. Okay, so this is the results of our efforts. You can see that we are trending below the center line. We had an uptick there in 1 month, I believe that was March. Not really sure what that was attributed to, but my guess is probably something to do with respiratory. But we have pretty much stayed below that center line, so we're maintaining our momentum here. The same with the 30-day readmissions. We truly are focused mostly on the 7-day because we thought that was our greatest opportunity for improvement. So we're not satisfied with where we are. You're always looking to make further improvements. So let's go to the next slide. So for 2019-2020, we are looking to implement a predictive risk tool to identify patients at high risk for readmission. I'm going to share a couple tools that we're looking at with you and talk to you about our strategy there. We're, like I talked about, the coordination of the post-discharge follow-up phone calls so that we're not inundating families with those calls. We've selected a folder that these go in so that anybody's making that call can see another person's call. And we're putting everything, it's automatically generated into an encounter form so that you can see who they're supposed to follow up with, when they're supposed to follow up, what medications or special equipment was ordered. So that's shared across all encounters. We are using some, trying to break down those patient family surveys further, doing some more analytics with that to look at other factors that may affect our readmissions, which may include, some social determinants of health, which we're doing social determinant of health screening using the SEEK tools now. Then looking for our high utilizers, those patients with more than 4 admissions per year, and their principal and secondary diagnosis to see if we can come up with specific interventions for them. So we can go to the next slide. I feel like I'm rushing through this stuff. Mercy Hospital, this is one that we are going to try here. And let's flip to the next one as well, the next slide. And this is we're going to take a group of patients that we know were unplanned readmissions, and we have a team of people that are going to apply these risk screening tools to those patients' records to see would they predict the readmission risk for our patient. And from that, we're going to decide which one we're going to have embedded into our electronic medical record. And with these readmission risk assessments, what you do is identify your high risk going down to your low risk, and then define specific interventions or bundles of interventions that you would apply to that risk group to prevent their future readmission. So I think that is all that I have. It is. I hope I didn't fly through that too fast. Do any of you have questions?
Well, Cindy, thank you. We'll open the floor now to questions. Your presentation was not rushed. I think you did a good job with it by all means. So we'll see if anyone has questions. We're monitoring the question box now. And okay. Abraham can read the questions off for us as soon as we see them.
Okay, so Cindy, I see one question that's come in. Someone said, are you prioritizing patients to call to get to that 200 per month?
Yes. So the way that we prioritize is, were they set up with post-acute care services? Are they taking a medication that if they did not get that medication, we know it could result in a readmission? Those are the ones that are being called from patients that have had an encounter in urgent care, emergency room, or discharged from the hospital as either an inpatient or an observation patient. So with that will be really comprehensive. We'll be touching almost all of the patients that are discharged. And then surgical patients, of course, get a follow-up phone call.
Okay.
Excellent. So we got another question pertaining to schedule appointments. Do you arrange both PCP and specialty appointments?
So, you know, that it can get pretty overwhelming making all of those appointments, and some of the offices actually won't let anybody other than the family make the appointment because of their no-show rate. So we prioritize. So patients, we ask if they would like to have assistance with making their follow-up appointment. If they say yes, then if the primary care office requires that the family do it, then we dial and get the family on the phone, or we say we're calling on behalf of the family at their request. We do prioritize particularly the patients that come in with the specialist, because obviously they are harder to get appointments with. So we make sure through the attending that their offices know that this is a follow-up to an admission. So I hope I answered that. It's the case managers and the social workers work collaboratively on this, along with our residents.
Excellent.
And if we don't make the appointment, the time frame for the follow-up is included and expected to be included on the depart summary and the discharge instructions that are provided to the family.
Okay.
I think we've got another question in here, if I can get to it. The risk assessment tool is very interesting. Has this tool been used in other pediatric settings and validated?
Yes, the HARPS tool from Mercy Children's Hospital in, I believe they're in Kansas, has been validated, and they actually did it. They started out with that as a quality improvement initiative and then decided to take it on as a full research and developed a protocol and got a IRB approval. And so, yes, that tool has been validated. Then the second tool that I showed you is from Seattle Children's, and they used it as a quality improvement project, and they validated it within their own health system.
Okay.
Excellent. Joyce, I'm not seeing any more questions at this time.
Okay, thank you, Abraham. Cindy, we want to thank you so much for taking time out of your very busy schedule to share this very excellent and informative work that you all have been doing to help with care transitions and prevent readmissions. And also I ask that you give our thanks to Adam and his work he's done there with you as well.
Definitely. Yep.
For our attendees, our last webinar of this year will be, as I said before, Thursday, December the 5th from 12:30 to 1. And as we close with the webinar today, please remember that the feedback survey will pop up when we end this session. And I hope you all have a wonderful fall day. It's absolutely beautiful outside, and we will chat with you in December. Have a great Thanksgiving as well, and Halloween.
Thank you so much.